Hello and welcome to a YouTube tutorial. My name is James Piper. I'm a Senior Fellow and a Lecturer in Acute Medicine at the University College of London. Welcome and thank you for listening. Don't forget to subscribe and leave your comments or questions on the video. Today I'm going to be talking about pericardial disease. And I'm going to focus on four particular sections: the epidemiology and etiology of pericardial disease, some pericardial syndromes, causes of pericardial disease, and then finally interventions and treatments, with a short section on cardiac tamponade. Let's just remind ourselves of the anatomy of the pericardium. So it's a double-walled sac. It contains the hearts and roots of the great vessels, and it has a particular role in fixing the heart to the mediastinum, protection against infection, and of course lubrication for the heart. The classification of pericardial disease is shown on the slide here. So pericarditis can of course be an isolated disease or part of a systemic disease. Pericarditis can fall into categories such as acute, subacute, chronic and recurrent. Other pericardial diseases include pericardial effusion, cardiac tamponade, constrictive pericarditis, and pericardial masses. So epidemiology of pericardial disease is relatively common. This is data from an Italian study by Immazio et al. In 2008, which shows a prevalence of about 27.7 per 100,000 of the population. And although it does account for only a very, very small proportion of hospital admissions, in fact 0.1%, it does account for a slightly higher proportion of emergency department attendances for chest pain. Young men are the most commonly affected group, and overall men are more affected than women. It's important to note that pericarditis can recur, and recurrences affect about 30% within 18 months of the first episode. When you look at some of the causes now of pericarditis, the most common causes are viral, and they include things like enteroviruses such as Coxsackie and echoviruses, herpes viruses, the adenoviruses, and parvovirus. Other causes include bacterial, of course, fungal and parasitic, but fungal and parasitic infections of pericarditis are extremely rare. Bacterial agents causing pericarditis include Mycobacterium TB, especially in the developing world, Coxiella, Burnetii, Borrelia burgdorferi, which is also known as Lyme disease, and there are other rare agents. The second group, of course, is non-infectious causes, and of this group, autoimmune are the most common. For example, systemic autoimmune and anti-inflammatory diseases such as SLE, Sjogren's syndrome, rheumatoid arthritis, and scleroderma. You also have the systemic vasculitides such as eosinophilic granulomatosis, polyangiitis, or allergic granulomatosis, previously named Churg-Strauss syndrome. You can also have others such as sarcoid, familial Mediterranean fever, inflammatory bowel disease, and Still's disease. Of course, you can get malignancy of any part of the body, and the pericardium is no exception, although primary pericardial tumours are relatively rare. You can get metastatic tumours, which are fairly common, above all lung, breast cancer, and lymphoma. You can, of course, get uremic and myxedemic and anorexia nervosa-induced metabolic pericarditis, but also cause trauma, which of course, such as penetrating thoracic injury, such as a stab wound to the chest. Drug-related are relatively rare, and again, the drugs which may cause drug-induced pericarditis are on the slide. So acute pericarditis is an inflammatory pericardial syndrome with or without pericardial effusion. Chest pain is seen in the vast majority of patients, in fact over 85%, who describe the pain as sharp, pleuritic, and what's key, particularly if you're studying for exams, is that it's improved by sitting up and leaning forward. Further diagnostic elements of pericardial disease include chest pain, as I've just said, a friction rub, sometimes that can be relatively hard to hear. ECG changes are present in up to 60% of pericardial disease, and that includes new widespread ST elevation and PR depression. You may see pericardial effusion, and that's best diagnosed via transthoracic echo. There may be systemic fever. You may also see an inflammatory response such as a raised white cell count, CRP, and ESR. You may also see if there's evidence of tissue damage, such as via myocarditis. You may see a raised creatine kinase and troponin levels if myocarditis. So, when we look at the definition and diagnostic criteria, my reference text for today is the European Society of Cardiology on Pericardial Disease. Again, a fairly good read, especially if you are preparing for exams. So, acute pericarditis is inflammatory pericardial syndrome to be diagnosed with at least 2 of the 4 following criteria: pericarditic chest pain, pericardial rubs, new widespread ST elevation or PR depression on ECG, and a new or worsening pericardial effusion. And as I said, other supportive findings will include elevation of markers of inflammation and pericardial inflammation on imaging such as CT or cardiac MR. Incessant pericarditis means pericarditis lasting for more than 4 to 6 weeks but less than 3 months without remission. Recurrent is recurrence of pericarditis after a documented first episode of acute pericarditis and a symptom-free interval of 4 to 6 weeks or longer. Chronic pericarditis is chronic pericarditis that lasts over 3 months. So pericardial friction rubs can be tricky to hear. If you search on YouTube, you'll find 1 or 2 good sites on how it sounds. Unfortunately, it's difficult augmenting audio clips into a recorded presentation, but superficial scratching or squeaking is how it may often be described, best heard with the diaphragm of your stethoscope at the left sternal border. So what we're going to do now is have a look at some ECGs which are associated with pericarditis. So this is the first one, and I'd like to credit Life in the Fast Lane for the ECG extract. So this is pericarditis ECG 1. So if you have a look at this ECG, you have widespread concave ST elevation and PR depression is present throughout the precordial, i.e. the chest leads V2 to V6 and the limb leads in 1, 2, AVL and AVF. Of note, there's also reciprocal ST depression and PR elevation in AVR. Now, it's important here when you're thinking about, for example, ST elevation MI, note that pericarditis tends to be common in younger patients. So certainly, if a 25-year-old presents with this ECG, this should certainly be at the top of your list, pericarditis, as opposed to an acute coronary event, which is highly unlikely. A second pericarditis ECG, here you have widespread tachycardia, concave ST elevation and PR depression in 1, 2, 3, AVF and leads V4 to V6. There's also reciprocal ST depression and PR elevation in V1 and AVR. Again, pause the video and make sure that you have studied the ECG carefully so that you can see the changes I'm referring to. Now, when you have a look at a chest x-ray, usually the vast majority of chest x-rays in pericardial disease are normal unless there is a significant effusion. And what I mean by significant effusion is an effusion that's at least 300 mils, and that's the case on this x-ray. So our initial investigations are going to include an ECG, transthoracic echo or TTE, chest x-ray, a CRP and white cell count, and a creatine kinase or troponin. Most of us will now use troponin to look for signs of myocardial injury. So what's important in the first levels of investigation? So I've already just outlined the primary investigations that you should do in the evaluation of pericarditis. You can also, of course, do renal function, liver tests and thyroid function tests. But the second level is, of course, to evaluate the pericardium anatomically by doing a CT and or a cardiac MR. And, of course, if possible, do perform analysis of pericardial fluid from either a pericardial centesis or surgical drainage, and also consider additional testing for specific etiologies, which we'll discuss in a little bit more detail later on. If you do obtain pericardial fluid, and again this really does depend on the expertise available and the size of the fluid and its accessibility, you're going to perform similar fluid analysis that you do, for example, with a pleural effusion. So you're going to measure the protein level, the glucose level, and also do the LDH. You'll also send samples for cytology, PCR for TB possibly, and also send it to microbiology. So how do we manage simple pericardial disease? Well, most of the time you don't need to search for the etiology, particularly in low-risk patients, as performing vast quantities of viral screens will only achieve little and have a relatively low yield of investigations. Patient needs to rest, treat until normalization of the CRP, and usually the treatment is aspirin or non-steroidals, and that's based on patient assessment and whether they can tolerate aspirin or non-steroidals, for example. You can alternatively use colchicine in low dose, and second line of treatment is also prednisolone. Now, what are the features that carry a poor prognosis and therefore we need close follow-up and involvement of cardiology? Well, these include major criteria such as a fever of greater than 38 degrees Celsius, subacute onset, a large pericardial effusion, cardiac tamponade, and lack of response to aspirin or non-steroidal therapy after at least a week of therapy. Minor predictors of poor prognosis include myopericarditis, immunosuppression, trauma, and anticoagulant therapy. This here is an extract from the flowchart from the European Society of Cardiology, which outlines the steps that you should take in managing pericardial disease. So your initial analgesic regime, as I've said, it's important that you're going to prescribe some anti-inflammatory therapy for acute pericarditis, and you basically have three options here: aspirin, ibuprofen, and colchicine. It's important to realise as well that you're using higher dose of both aspirin, ibuprofen. Colchicine is a relatively standard dose, but particularly you'll notice that aspirin and ibuprofen is being used in relatively higher quantities. So aspirin is 750 to 1000 milligrams every 8 hours for 1 to 2 weeks, and then ibuprofen is 600 milligrams every 8 hours for 1 to 2 weeks, and then you taper down both of those. Colchicine, however, has a 3-month treatment window, and that's 0.5 milligrams once a day if they're less than 70 kilos, or 0.5 milligrams twice a day if they're over 70 kilos. So assuming that your treatment plan goes well, most of the time the prognosis of pericarditis is good. Tamponade is rare and usually occurring with patients with malignancy or associated TB. The risk of constriction, however, does occur in autoimmune and neoplastic pathologies. Of note, colchicine will halve the chance of recurrence, and if not used, 50 to 30% will cause recurrent disease, and that's why it may be that you opt for colchicine as your first line agent. So this is just a chart here to outline your flow of treatment plan for acute pericarditis. So you have your diagnosis of acute pericarditis. First line treatment is aspirin or non-steroidal plus colchicine plus exercise restriction. Second line is low dose corticosteroids, and I've put the dose on the right hand side. Recurrent pericarditis, so i.e. if after a symptom-free interval of 4 to 6 weeks the pericarditis comes back, again you would try aspirin or non-steroidal and colchicine plus exercise restriction, low dose steroids followed by IV immunoglobulin or Ankara or azathioprine as immunosuppressive agents. Fourth line would be referral and planning for a pericardectomy. So again, if you have recurrent pericarditis, the analgesic here is fairly similar to the prior table, except that you'd use aspirin, ibuprofen, and colchicine for longer. You'd use colchicine for at least 6 weeks, and you use aspirin this time for weeks to months. So myopericarditis has similar etiologies of that of pericarditis. Your chest pain is associated with signs of pericarditis, and often you'll have an elevated troponin level. In viruses, you get cellular inflammation, and you can also get immune complex disease such as connective tissue diseases and inflammatory bowel disease. You may also present with concomitant infection, and the patient may need angio plus or minus a cardiac MRI. Treatment is with high-dose steroids and non-steroidals, and usually the patients will make a good prognosis. So pericardial effusion, so normally patients will have about 10 to 15 mils of fluid surrounding the heart in the pericardium. Of course, inflammation will cause an exudative production of fluid, hence you'll get a build-up of your infusion. Sometimes if you have a raised venous pressure, such as in CCF, you'll get reduced absorption of the pericardial fluid. So when you're thinking about the the size of your pericardial effusion, again, it's classified according to acute, subacute, and chronic, mild, moderate, and large, circumferential or loculated, and transudate or exudated. Again, pericardial effusions are often asymptomatic, they are an incidental finding, and it's idiopathic, i.e., there's no identifiable cause in up to about 50% of cases. Cancer occurs for about 10 to 25%, and infections another 15 to 30%. Connective tissue disease a small proportion, and in developing countries the TB is particularly significant in up to 60%. So the presentation and diagnosis of pericardial effusion will of course vary according to the speed of the accumulation of fluid. Patients will often complain of a shortness of breath, orthopnea, chest pain, and a feeling of fullness. You may, in significant effusions, get compressive effects which will cause nausea, dysphagia, hoarseness, and hiccups. You may also see fever, infection, or evidence of autoimmune disease. Clinical examination may be normal. In tamponade, remember you're listening out for diminished heart sounds, pulsus paradoxus on ECG, and neck vein distension. Pericardial rubs are relatively rare, and diagnosis is with echo. Chest X-ray, cardiac MR, and inflammatory markers should be performed. So if you have a look at this image here, you can see that if you look where the black fluid is here, you have evidence of pericardial effusion. So it's important when you're assessing a pericardial effusion to assess its size, hemodynamic compromise, and any associated diseases such as hypothyroidism. And your management strategy for pericardial effusion is to treat the underlying disease. It may need drainage plus or minus insertion of a pericardial drain, and there are no proven therapies for isolated effusion. Looking back now at our European Society of Cardiac Guidance, you can see that if there's no evidence of cardiac tamponade and there's evidence of raised inflammatory markers, then you would treat with anti-inflammatory therapy. And then if there's no evidence of inflammatory markers, you would proceed as shown in the diagram. You'd be looking for where there's associated diseases, try and treat the disease. If not, you'd potentially consider pericardial centesis and drainage. If the effusion is small, you consider just doing serial echoes. So prognosis and follow-up of pericardial effusion. So the prognosis is usually related to the etiology, and the size of the effusion is correlated with the prognosis. So large idiopathic chronic effusions that are present over 3 months have a 30 to 35% risk of progression to cardiac tamponade. The follow-up of pericardial effusion is mainly based on the evaluation of the symptoms and the echocardiographic size of the effusion, as well as additional features such as inflammatory markers like CRP. A mild idiopathic effusion, which is less than 10 millimeters, is usually asymptomatic, generally has a good prognosis, and does not require specific monitoring. Moderate to large effusions, however, may worsen, and especially severe effusions may evolve towards cardiac tamponade in up to a third of cases. So follow-up echocardiogram should be arranged every 6 months, although for a severe effusion, an echocardiogram follow-up may be every 3 to 6 months. Just a quick slide on constrictive pericarditis, just to say that constrictive pericardial disease can occur after any episode of pericardial disease, more common in bacterial and purulent pericarditis, and there are signs and symptoms of right-sided heart failure. Diagnosis is via echo, cardiac magnetic resonance imaging, and possibly a catheter procedure, and the treatment primarily may be surgery and medical therapy. Now I'm going to focus on cardiac tamponade, which for those of you studying at UCL is a core condition in cardiology. So cardiac tamponade is a life-threatening emergency, and it involves rapid compression of the heart. Now, what can be compressing on the heart and filling the cardiac tamponade include substances such as pus, blood, fluid, and clots. In significant cases, cardiac tamponade leads to inflammation, can be seen in trauma, and also rupture and aortic dissection. And clinically, you're looking for tachycardia, hypotension, raised jugular venous pressure, muffled heart sounds, decreased ECG voltage, and enlarged cardiac silhouette on a chest X-ray. So common causes of cardiac tamponade include pericarditis, TB, iatrogenic, so for example invasive procedures or post-cardiac surgery, trauma and neoplasm or malignancy. Rarer causes of cardiac tamponade include collagen vascular diseases, radiation-induced post-myocardial infarction, uremia, aortic dissection, bacterial infection, and pneumopericardium. So I'd like to have a quick look at this ECG and just pause the video here and just have a look at what you think, which phenomenon is being displayed on this ECG. So just pause here until you have the answer. And so this phenomenon that you're looking for on this ECG is known as electrical alternans. And so again, a good source of reference to look at electrical alternans is lifeinthefastlane.com. And you can basically see consecutive normally conducted QRS complexes that alternate in height. And electrical alternans occurs when the heart swings backwards and forwards within a large fluid-filled pericardium. Patients with this ECG pattern need to be immediately assessed for clinical and echocardiographic evidence of cardiac tamponade. I promise I have no deal with these people, but just to also point to another resource as well as Life in the Fast Lane, a very good video is by the New England Journal of Medicine, which goes through how to perform an emergency pericardial centesis procedure. It's about 10 minutes long. I have to say it's a really good very good video rather of how to perform the procedure and one of the things that you're looking out for, and is well worth the watch, and I've put the link on there. So when you're performing an emergency and you're also going to take a syringe, and as you can see here you're going to take a subxiphoid approach, obviously using ultrasound as you'll see in the video, and try and aspirate the pericardial fluid. Another good resource for you is this is by the Cardiothoracic Society net video. It's a demonstration, again it's only about 5 minutes long, on a subxiphoid pericardial window. Obviously don't try these procedures at home, and I've put the link to on the video on there. So that concludes this 20-minute video on pericardial disease. Again, my resource text for today is European Society of Cardiology Pericardial Disease Guidance. Thank you for listening. Please think about liking, commenting and subscribing with very best wishes, and I look forward to hearing from you at the next video.